this is about heart failure treatment across left ventricular ejection fraction spectrum. I think we have had two interesting talks on heart failure with primary focus on heart failure with reduced ejection fraction. We all know we have different varieties of heart failure. We categorize them according to the ejection fraction. You can have heart failure with reduced ejection fraction. The patients who have signs and symptoms of heart failure with ejection fraction less than 40%. Heart failure with mid-range ejection fraction where EF can be between 41 to 49%. And heart failure with preserved ejection fraction where you have symptoms and signs of heart failure with ejection fraction more than 50%. With objective evidence of cardiac structural or functional abnormalities consistent with the presence of LV diastolic dysfunction or raised LV filling pressures including elevated natriuretic peptides. So, we have these patients, they move across the spectrum. The patients whom you have seen with a reduced ejection fraction can have a recovery and end up in mid-range or preserved ejection fraction. Same time, the patients whom you have seen with normal ejection fraction can slowly progress into other way around with the reduced ejection fraction also. The prevalence of different types of heart failure is changing over the time. If you look at the earlier decades, 1985 to 94, the most of the patients presented with heart failure with reduced ejection fraction. Now you could see more and more patients are presenting with heart failure with preserved ejection fraction. So with the increasing life expectancy and aging population, we see more patients who are presenting with heart failure with preserved ejection fraction. And there is also a significant change in the way patients are living after a cardiac event. You know there is an increased survival after a clinical cardiac event like coronary artery disease, and rate of AF is increasing as the population is aging more. And not only that, we are also able to recognize and diagnose more patients with heart failure now with better diagnostic facilities. Every patient who has a heart failure, each hospitalization will bring the patient close to the mortality. So the most important concept in heart failure management other than other cardiac diseases, prevention of hospitalization. It is a hard endpoint in heart failure where not only you look at mortality, you also look at heart failure admissions also. So if you look at all three types of heart failure, you could see there is not a significant difference between readmissions and mortality. If you look at most of them look same. Heart failure has highest 30-day readmission rates compared with other diagnoses. So you admit a patient with heart failure, the chances that he has to get admitted within 30 days is pretty high. And mortality significantly increases after every admission. So mortality rate risk remains urgent and life-threatening for patients with heart failure. You could see as the patient progresses further and further into a heart failure journey, you could see a significant increase in the number of admissions and mortality. So whenever you see a patient with heart failure, you have a definite goals in your management protocol. You want to reduce mortality, the primary aim. And the second primary aim is prevention of recurrent hospitalization due to heart failure. And definitely, the more importantly, you want to improve the clinical status and functional capacity and quality of life. So if you look at the new heart failure guidelines, they have become pretty simpler now. You have to put the patients on pillars of heart failure management. You put them on ACRB, ARNI, beta blockers, MRA and SGLT inhibitors. If patient has a signs of fluid retention, you consider adding a loop diuretic. If patient has an ejection fraction less than 35% and QRS is less than 130 milliseconds, if appropriate, particularly in a ischemic heart disease patient, you can consider putting a ICD for prevention of sudden cardiac death. If a patient has an ejection fraction more than 35% and device therapy not indicated or appropriate and symptom persist, you can consider other therapies which are available, class 2 therapies which can be added, like Sir told about Versigad and other newer drugs, you can add them. If a patient has a sinus rhythm, EF 30% and QRS is more than 130 milliseconds, these patients are candidate for a CRT. If it is an ischemic patient, you consider putting a CRT-D, which has a ICD inbuilt, or CRT-P in case of a non-ischemic cardiomyopathy. So, if you look at patients with preserved ejection fraction, there is a significant difference because there are few drugs which you use heart failure with reduced ejection fraction which have a good outcome trials in patients with preserved ejection fraction. SGL inhibitors is one of among the drugs which has shown good benefit in patients with preserved ejection fraction. If you have a patient with preserved or mid-range ejection fraction, the management is little different compared with patient with reduced ejection fraction. Here you may need more diuretics because a lot of these patients are congested more, and you have to use either DAPA or EMPA for disease modifying effect. ACE, ARB, ARNI, MRA, beta blockers all have a limited role, except that ARNI has shown in some group of patients, particularly patients of ejection fraction in a range 40 to 50 has a role. When you cross ejection fraction more than 50%, there are very few drugs which have shown outcomes. One among them is a SGLT inhibitor. So SGLT inhibitors we know has a multiple mechanism of action, and if you look at guideline directed medical therapy, the guideline directed medical therapy, when you combine all together, ACE or ARNI, beta blocker, MRA and SGLT inhibitors all in combination has the best possible outcome. So whenever you have a patient with heart failure, your primary aim should be to add all the drugs possible, and slowly introduced as a diabetic drug. SGLT inhibitors has become primarily a cardiac drug, particularly in heart failure management. Now you see lot and more indications are evolving for SGLT inhibitors, starting from heart failure with reduced ejection fraction. Now we have recommendations for heart failure with mid-range or preserved ejection fraction also. So we have data from a large trials that DAPA or SGLT inhibitors have a significant reduction in cardiovascular death and worsening heart failure in patients with reduced ejection fraction. So when you have an ejection fraction more than 40%, as I told you, we have very limited options. If you look at sacubitril valsartan, if you look at spironolactone, if you look at ARB or ACE, most of the trials have not been very fruitful. The data was not very convincing. None of the drugs have shown a clear benefit in patients with preserved ejection fraction. EMPA was the one among the drugs where it could deliver a good data even in patients with preserved ejection fraction. SGLT inhibitor as a group shown to improve patients with ejection fraction which is in the mid-range or a preserved level also. DELIVER is a good trial. It's the largest and broadest trial today in patients with heart failure and mildly reduced or preserved ejection fraction, where you could see a significant improvement. A primary composite endpoint of cardiovascular death, heart failure admissions, urgent heart failure visit has been significantly reduced with 18% relative risk reduction. And one thing you always see in most of the trials with SGLT inhibitors is the early onset of benefit. This is one among the drug with heart failure which has a very early benefit. You could see a benefit as early as 2 weeks. To compare with beta blockers, most of the beta blocker trials, you could see benefits at the range of 3 to 4 months, while SGLT inhibitors can deliver a benefit as early as 2 weeks. This benefit was consistent across all the subgroups. So this has put DAPA or SGLT inhibitors across full spectrum of EF, and if you look at the pooled analysis of both DAPA HF, which is on reduced ejection fraction, and DELIVER with preserved ejection fraction, you could see there's a significant improvement across the group. If you look at death, heart failure admissions, or major cardiovascular outcome, all were significantly improved when you look at SGLT inhibitors in these groups. If you look at comparative benefits of DAPA and EMPA, the two good drugs which are available, so both have shown good benefit. DAPA has a more data on patients with reduced ejection fraction, while EMPA also has a good data on patients both with reduced and preserved ejection fraction. So the benefit is spread across the spectrum of ejection fraction. So if you look at SGLT inhibitors, DAPA is the one drug which has a disease modifying therapies across LV ejection fraction spectrum. This is the reason SGLT inhibitors are recommended across the ejection fraction spectrum in patients with heart failure. We have shown benefit even on patients who had ejection fraction more than 50%, which was not with the case with most of the other drugs. if you look at the effect of DAPA, which was consistent with patients with or without ejection fraction less than 40%. Even on patients who had consistently better ejection fraction, still DAPA was able to show a better benefit. So if you compare head to head, EMPA has a good data even on patients with preserved ejection fraction. But if you look at patients overall cardiovascular death, that's a one area where Emperor reduced or Emperor preserved could not show a lot of benefit. And there was a one criticism which was there for EMPA preserved, where the mortality benefit was an issue. So if you look at the patients with heart failure, you could see that the drug DAPA has a better effect on patients across the spectrum of reduced, preserved and mid-range ejection fraction. So, so another thing which always we are worried is when you have a lot of other drugs available, like you have a lot of generic brands available. So one thing we have seen is most of these trials, what we see as a data are done with innovator brand. So it's very difficult until unless you prove that the preparations are same. Very difficult to postulate that all the outcome benefits what you achieved with original brands can also be brought to the generic brands which are available in market. To summarize, DAPA has a significant improvement in mortality and it has a significant effect on mortality reduction. It is recommended across spectrum of heart failure, including preserved ejection fraction. And most of the guidelines recommend one of the cornerstone of medical therapy for heart failure as SGLT inhibitors. And DELIVER, which was done on heart failure preserved ejection fraction, was shown significant reduction in composite cardiovascular death, worsening heart failure with all the components delivering the benefit. The pooled data also is positive. So when you have this data, I think SGLT has clearly shown that this is a one drug which have to be added in most of the patients with heart failure, and it has shown benefit even on patients with ejection fraction more than 50%. With this, I'll close my talk.